sensory nervous system. Let's talk about that. We're going to talk about the ear and the eye. Okay, so just really quickly, this is the anatomy of your ear. You have your outer ear, you have your middle ear, and you have your inner ear. Okay, your ear helps you with hearing and with balance. I'm not going to dive deep into this, but just if you need to brush up on your ear anatomy, please do so on your own. So the first thing we're going to talk about is otitis media, or the common ear infection. This involves the middle ear and the eustachian tubes. It will be caused by upper airway congestion and inflammation. So normally, if a small child has a cold or an upper respiratory infection, they are likely to be at increased risk for an ear infection, and that's because of the shape of a pediatric ear, and the eustachian tubes are flat and short, and so it's a lot easier for all of the gunk to get into those spaces and cause an infection. That's why adults don't get ear infections as often. So fluid will accumulate in there, and then it will grow bacteria or a virus and lead to infection and change the ear pressure. It can affect hearing and balance. And so usually self-limiting, right? But persistent infections can cause damage to the tympanic membrane and could lead to perforation or chronic otitis media or hearing loss. We'll usually screen it just based on presentation, irritability, restlessness, fever, ear tugging in children. There is some increased risk for otitis media in homes that have smokers or kids at daycare because they're obviously exposed to more viral infections. Pacifier use also has some correlation with increased ear infection and then being behind on vaccinations. So we talked about the ear inflammation and the pain. Okay, diagnosis is through physical exam. Here's a great picture of the difference between those eustachian tubes between children and adults, and you can see how different it is. Some kids might be dizzy because of the balance component. If there is a tympanic membrane perforation, it can lead to sudden ear pain relief, but they could also have vertigo or tinnitus or hearing loss. We will treat ear infections with antibiotics if it's bacterial, okay? Usually it's amoxicillin or azithromycin. However, there's a current trend of just watchful waiting. A lot of these will actually resolve on their own. And so sometimes we're not going to jump to antibiotics right away. However, if a child tends to have multiple ear infections in a small amount of time, we will consider tubes. Little incision that's made in the eardrum, and they'll put in tubes to reduce fluid buildup. We usually do it under general anesthesia, but it's a pretty simple procedure, and I think the standard is 4 or more ear infections within a year, and then they will have a tube consult so that we don't have recurrent ear infections because it can affect development, right? Speech, hearing, language acquisition, all of those things. I covered most of this. I'm not really going to dive into it a whole lot. Like I mentioned, they could have some language and hearing issues, so speech could be delayed depending on how often they have them. A persistent otitis media can cause conductive hearing loss, so that is a concern if they do have recurrent ear infections. But ultimately, for most kids, this is a pretty minor issue. All right. Moving on, hearing loss in general. This can occur due to dysfunction or damage to the structures involved in hearing. There are 3 types. We've got conductive hearing loss, which is caused by obstructions or malfunctions that block sound waves or damage from ear infections. We have sensory neural, which occurs in the inner ear, the cochlea, or the auditory nerve, and that affects transmission of sound signals to the brain. Or we could have mixed, which is a combination of conductive and sensorineural hearing loss. And it can be caused by infections like OM or meningitis. You might have heard kids getting meningitis. There was a show for a while, Switched to Birth, where one of the characters had meningitis as a baby and then became deaf. Noise exposure, birth trauma, high bilirubin levels leading to kernicterus can cause hearing loss, maternal infections, or genetics. So we will do routine screenings for hearing at well-child visits, all right? There's some cues as far as infants not responding to sounds consistently or startling at loud noises, or older children who might turn up the volume or seem inattentive. But ultimately, we want to do hearing screens and tests to determine if there is any hearing loss. Treatment and therapy is personalized to the child, right? If this is genetic, there is a lot of controversy in the deaf community about whether or not we treat hearing loss if it's genetic and they're from a deaf family. A lot of deaf families take pride in their deafness, and so there's some cultural components here as well. Other families might choose to treat and use things like cochlear implants or hearing aids, depending on if it's just hard of hearing or complete hearing loss. So there's a huge spectrum of what kind of treatments and therapies you use, and so it requires a lot of collaboration with the family and conversations about their goals and what they want for their child. As far as impact on health goes, it can impede their developmental milestones, especially in speech and communication. So a strong support system is essential if this child is born to a hearing family or acquires hearing loss and the family is hearing. Communication is going to be difficult within the family, and so there again has to be a discussion with the family on cochlear implants and hearing aids versus having the family and the child learn ASL or American Sign Language to help with communication, and having family members and friends participate in learning so that child doesn't lose accessibility to the family and to communicating with everybody like the rest of the family can. Alterations in vision. So strabismus is one of the big things we might see in kids. This is where the eyes don't properly align with each other, and that's because there's weakness or dysfunction in one or more of those 6 muscles that control eye movement. So depending on the muscle, you have different eye movement disorders. And so we will usually catch these with vision screenings. And then we'll refer to optometry or ophthalmologists for treatment here. Risk factors for strabismus include birth trauma or low birth weight, premature births, complications during delivery, or early illnesses. So lots of overlap here with some of the other sensory disorders. We can see signs of strabismus from squinting or misalignment of the eyes or closing one eye to focus. You could also maybe have some vomiting, headaches, double vision, or impaired depth perception. Usually what we'll do is use patching or corrective lenses or eye exercises. Just keep in mind, and this is an exam question, I feel like we patch the stronger eye. We want to patch the strong eye so that the weaker one has to work. We can also use atropine drops in the strong eye so that the weaker one has to step up and work. We can also do surgery to adjust the muscle around the eye to achieve proper alignment if that's necessary. So again, with all sensory, we think about emotional support for the child, collaborating with school so that we can help with accommodations if those are necessary, and then just encouraging prenatal care to help avoid any sort of prematurity or birth trauma, things like that that might lead to a higher incidence of strabismus. For teaching, we're going to teach them about eye drops, about how to wear the patch, when to not wear the patch, driving limitations as they get older if it's still occurring and it wasn't completely resolved, and then developmental needs for the child. Eye trauma is just when something goes in the eye that doesn't belong there. All right, so now we have an entry wound without an exit wound. That's a penetrating trauma. Okay, it goes in, it doesn't come out. We could also have a perforating trauma. Okay, that's an object that goes into the eye and exits at another point. Maybe it goes this way. So you have 2 wounds that can lead to extensive damage. You can also have a ruptured globe. So that's where the outer layers of the eye, like the sclera or the cornea, are punctured or torn. And so that can be from penetrating or blunt force trauma, like a hit to the eye that can cause an increase in intraocular pressure and then lead to a tear of the sclera. Risk factors for this are things like sports that have flying objects like baseballs, lack of protective eyewear, substances that impair judgment or balance that can increase the likelihood of eye injuries, or child abuse. The one that we see the most that I don't even see talked about in here is, I'm just taking this down at this point, retinal damage from shaking a baby. So non-accidental trauma in infants. When babies are shaken, they will often have retinal imaging done to look for retinal hemorrhages. Okay, so that's the most common eye trauma that I have dealt with clinically rather than injuries and things like this. But we will look into it with an eye exam, okay, do any imaging that needs to be done, and then the treatment's going to depend on what the injury is. But it's important to obviously treat this quickly because any injury to the eye could affect vision in the long term, and eyesight is huge. So we want to make sure that we prevent vision loss as much as we can. But recovery can be prolonged, which can lead to some developmental delays, such as mobility or toilet training or educational progress, depending on the age of the child. Retinoblastoma. Okay, I forgot this was on here because cancer is actually weaved into the systems now instead of by itself. So retinoblastoma is a type of cancer that originates from abnormal growth of cells in the retina. Okay, this is often due to a genetic factor. So it can cause cancer in one or both eyes and also leads to increased cancer risk in later life. All right. This accounts for about 2% of all childhood cancer, usually in children under 6, with a peak incidence of about 2 years old. And you might be familiar with this because this kind of went around on the internet for a while, where people were taking pictures of their kids, and instead of the red light reflex with the cameras from the flash, it would be white. And that was usually a sign that there was something going on with the retina. Young age is a risk factor here. Exposure to certain chemicals like gasoline, low maternal consumption of fruits and vegetables have been shown to have a little bit of a correlation. And so our clinical presentation here is going to be eye pain, vision changes, strabismus, bleeding, eye bulging, a non-reactive pupil, iris color change, or that white pupil reflex that I just mentioned. This will be managed by an ocular oncologist. I've never seen retinoblastoma clinically because I haven't worked in oncology, but they'll treat it like a cancer would be, so they're going to do chemo and radiation, surgery to remove the tumors. Cryotherapy can be used as well, which uses cold or laser treatment. And then the removal of the eye is called enucleation, and they can do that to improve survival rates. But it is important to know that enucleation does have an increased risk of metastasis, because when you go in there to take the eye out, it's pretty traumatic and it can cause cancer cells to spread. If somebody opts to have enucleation, then prosthetics can be provided so that we can at least improve body image and self-esteem. Rhabdomyosarcoma. Okay, this is in the cells of the connective tissue, like the skeletal muscle tissue. And it can occur in other parts of the body, but the eye is included here. The cause of it is not well understood, but it usually involves changes in the DNA within the cells that lead to cancerous growth. It represents about 3% of all college cancers, childhood cancers, and is the most prevalent soft tissue sarcoma in kids under 10. Increased risks are being male, under 10 years old, and having certain genetic syndromes like Noonan syndrome can increase your risk to this, as well as exposure to prenatal drugs like marijuana, cocaine, and radiation. You're going to see things like strabismus in these kids, eye bulging due to the actual tumor growth, and vision changes. If it's in other body areas, obviously the symptoms will vary depending on the location of the tumor. So once again, treatment is chemotherapy, that's one word, chemotherapy, radiation, surgery, and also you could use stem cell transplants for severe cases. Ocular cancer in general is just like any other cancer. It can be very stressful for children. There's a lot of frequent hospitalizations. There is the unknown in terms of morbidity and mortality rates. Children who have had cancer early can face developmental delays, social delays, all sorts of things just based on what stage of life they're in when this occurs and how often they're in the hospital. Okay? So we're going to be supporting these families a lot with outpatient therapies, with support networks, with child life specialists, with coordinating with the schools, all those things that come into this holistic treatment of cancer in children. Okay, it is important to know from a PED standpoint that children that are undergoing cancer treatment, that are getting radiation or chemo, should avoid live vaccines. So if they're at the age that they would be getting like the MMR, for example, we need to avoid live vaccines and still exercise caution with those inactivated vaccines due to their health status.